Hello, and welcome to our webinar, Cholesterol, Inflammation, and Heart Disease. This is part of our Community in Action program at the FH Foundation. And for this webinar, we have with us Dr. Mary McGowan, the Chief Medical Officer of the FH Foundation, to present on this topic. My name is Kat Davis Ahmed. I'm the Vice President for Policy and Outreach at the FH Foundation, and I'm very happy to have you all here. First, I'd like to remind everybody that this information in the webinar is for all of you. It's an educational webinar, but it's not intended to be a substitute for professional medical advice or diagnosis or treatment, nor does it constitute medical advice or other professional advice. Information can change and be updated, so please consult with your doctor or other members of your medical team for specific information pertaining to the treatment of you or your family. So it'd be wonderful if you'd all say hello in the chat if you feel comfortable and introduce yourselves to each other. Please choose panelists and attendees if you want everybody to see your hello. You might say where you're tuning in from. We've built in a lot of time for Q&A after Dr. McGowan's presentation. And so if you have a question, please put your questions in the Q&A box, where you can find that down at the bottom of your screen, usually in this Q&A box. And we really look forward to your questions. We'd like to thank our generous sponsors for their support, our Community in Action sponsors, Amgen, Esperion, Konica Medical Products, and particularly the FH family partners, families who have donated to support programs like these educational programs. Thank you very much. So for this webinar, we're addressing cholesterol, inflammation, and heart disease, how cholesterol causes atherosclerosis, inflammation, and immune cell dysfunction. And I'm just thrilled to have Dr. Mary McGowan here. She's the Chief Medical Officer at the FH Foundation and co-director of the Lipid Clinic at Dartmouth Hitchcock Medical Center. Thank you, Dr. McGowan.
Thank you, Kat. And welcome to everybody. I looked at the list and I see some old friends and lots of new people who have signed up for this. So I'm very happy to be here. And as Kat said, to speak about cholesterol, inflammation, and heart disease. Next slide. So I have some goals for this conversation tonight. I would like to help you understand what cholesterol is and how it starts the process of atherosclerosis. I think it's important for us to understand all the players in the initiation and progression of atherosclerosis. And I'd like to provide you with the ability to knowledgeably respond to people that you will meet that are cholesterol skeptics. I can tell you, I meet these people in my clinic, people who come in and say, I don't need to be treated for my cholesterol because atherosclerosis is all about inflammation. And I will not discount that atherosclerosis involves inflammation, but cholesterol is very important and is, in fact, the instigator of atherosclerosis. And I'd like to help people understand the importance of treating cholesterol early and aggressively, especially in situations where people are born with genetic cholesterol abnormalities, such as familial hypercholesterolemia. Next slide. So what is cholesterol? And this is a busy slide, and I'm going to spend a little bit of time on it. Cholesterol is a white, waxy, fat-like substance. It's produced in all of our cells, and it's used to produce hormones, vitamin D, and cell membranes. For most people, about 75% of the cholesterol is produced in the body, principally in the liver, and then about 25% comes from our diet. We can use a formula for telling people what total cholesterol is. So total cholesterol is really comprised of HDL cholesterol, that's the good cholesterol, LDL cholesterol, also known as the bad cholesterol, and then your triglycerides divided by 5. So that's why the things in your lipid panel don't all add up to total cholesterol. So why do we divide triglycerides by 5? Triglycerides are housed in something called VLDL, very low density lipoprotein. And this is made by the liver. And the VLDL has 5 parts triglyceride to 1 part cholesterol. So if you divide triglycerides by 5, you will get the cholesterol in VLDL. And then looking over on the right-hand side, so I'd like to take you through your diet. So we consume dietary fat and dietary cholesterol. That finds its way into the stomach, where the dietary fat can be saturated fat, it can be monounsaturated fat, and it can be polyunsaturated fat. And those fatty acids, as we call them, are put on, 3 fatty acids get put on a glycerol backbone, and that's what a triglyceride is. And we package the triglycerides and the dietary cholesterol into something called chylomicrons. Chylomicrons are very large. They contain 10 parts triglyceride to 1 part cholesterol, and they're absorbed in the gut. And I don't know if you'll be able to put the arrow there, Kat, but absorbed into the intestinal lymph. As you can see, it's green as depicted here, and then gets into the blood vessel. There, chylomicrons get acted upon by enzymes, and the triglycerides are released, and you end up with a cholesterol-enriched chylomicron remnant. And that goes to the liver, and the liver accepts this and uses that cholesterol from dietary origin, and then cholesterol that it makes to make something called VLDL, as I've already referenced. VLDL is 5 parts triglyceride to 1 part cholesterol. It's made in the liver, gets shipped out into the blood, where that VLDL gets acted upon by enzymes to release the triglycerides, or to release the fatty acids. Those fatty acids can go to muscle cells for immediate energy, and can also go to adipose tissue or fat tissue for storage. And then ultimately, that VLDL gets broken down first to IDL, intermediate density lipoprotein, and then to LDL, or the bad cholesterol. So where does that LDL that's in the bloodstream go? It can go back to the liver and go attach itself to the LDL receptor. If it attaches itself to the LDL receptor on the surface of the liver, that LDL gets brought into the liver. Now, what happens if you have a disorder called familial hypercholesterolemia? In this situation, people have fewer LDL receptors, so that in the blood, LDL cholesterol builds up. And that's when it can find its way into the artery. Well, not everybody who has atherosclerosis has an elevated LDL because they have familial hypercholesterolemia. Even though FH, or familial hypercholesterolemia, is common, occurs in 1 in 250 people, most people with atherosclerosis don't have FH. And so what's another way you can get LDL building up in your bloodstream? Another way is by eating a diet rich in saturated fat and cholesterol. A diet rich in saturated fat leads to something called downregulation of LDL receptors. In other words, we make fewer LDL receptors. So people who consume a diet rich in saturated fat may have an elevated LDL cholesterol because they downregulate their LDL receptors. And there's certainly other forms of genetically elevated cholesterol that can lead to elevated cholesterol in the bloodstream. Next slide. So atherosclerosis is complicated. I'm not going to deny that. And we're going to go through this rather slowly. And by the end, you might know more than your physician. But all evidence points to LDL cholesterol as the prime instigator of atherosclerosis. And atherosclerosis is defined as a disease of the arteries characterized by the deposition of plaques, plaques made of fatty material in the inner wall or intima of an artery. Once LDL gets into the artery, lots of other cells types get involved. So we have endothelial cells, and I'm going to introduce you to each of these. Endothelial cells, monocytes, which are also white blood cells, smooth muscle cells, immune cells such as T lymphocytes that can get involved in atherosclerosis, and even red blood cells. Next slide. So let's talk a little bit about the evidence supporting LDL as the prime driver of atherosclerosis. So based on evidence from genetic, epidemiologic, and clinical trials, Brian Ferentz and colleagues have concluded that the cumulative exposure of an artery to LDL over the years is the principal determinant of both atherosclerotic disease initiation and, in fact, its progression. And I'm going to talk to you right now about two ends of the spectrum, people who have genetically elevated LDL and people who have genetically very low LDL. And it may be that the people who have the very low LDL give us even more information. So additional evidence supporting LDL's causal role in atherosclerosis is the fact that untreated individuals who have familial hypercholesterolemia, who have genetically elevated LDL from birth onward, achieve this cumulative LDL exposure very early in life, and they develop premature atherosclerosis. They can have no other risk factor but elevated LDL. And this is particularly true, as we'll see when we get to the next slide, for homozygous familial hypercholesterolemia. But on the other hand, there are individuals, and we can talk about the particular genetic mutations if people are interested, but there are people who are lucky enough to have genetic mutations that lead to lifelong, very low LDL. And when I talk about that very low LDL, I'm talking about LDL levels of 20, 30, even lower than that. They are protected from the development of atherosclerosis. And what's most important to think about is they are protected even if they have other risk factors. For example, people with very, very low LDL cholesterol can smoke, can have diabetes, and can have hypertension. They don't get into trouble with atherosclerosis. Now, they can get into trouble with other things. If they smoke, they can get into trouble with lung cancer. There are a host of things that people who have diabetes and hypertension can get into trouble with, but probably not atherosclerosis if they have lifelong, very low LDL. These are rare mutations, though. So if you have any of those situations, make sure you're working on those risk factors as well. And the degree of protection that somebody who's had lifelong low LDL cholesterol is much greater than people who get very low LDL because they go on, for example, statins or ezetimibe or the PCSK9 inhibitors or bempedoic acid. These are medications that we use once people are usually a little bit older and we know that they have very elevated LDL. But the people who are born with very low LDL cholesterol have had it all their life. And so they are lucky genetically. Next slide. Now let's talk a little bit again about heterozygous familial hypercholesterolemia. That means you've inherited a single gene for familial hypercholesterolemia, and homozygous familial hypercholesterolemia. But let's first talk about people without those issues, without heterozygous or homozygous FH, because the bulk of people who develop cardiovascular disease in the United States are people who don't have familial hypercholesterolemia. And this slide comes from Barg Norgesgaard, who has depicted on the x-axis, the parallel x-axis age, a person's age, and then on the y-axis, LDL level and cumulative LDL exposure. And so if somebody does not have familial hypercholesterolemia, they cross the threshold for the development of atherosclerosis or cardiovascular disease, coronary heart disease, CHD, at around the age of 55. Now, this is modulated. Cholesterol is the prime driver, but it's modulated by other risk factors, as we well know: smoking, high blood pressure, diabetes, high triglyceride, low HDL, elevated lipoprotein little a. And there are certainly risk factors and beneficial risk factors that I've talked about, that having a mutation that causes very low LDL, you would cross that threshold many, many years later. And women are generally protected from atherosclerosis, symptomatic atherosclerosis, until after menopause. Individuals who have heterozygous familial hypercholesterolemia have inherited a single gene for elevated cholesterol, and they can have no other risk factors, but if they're untreated, they will typically cross that threshold for CHD, coronary heart disease, atherosclerosis, at around the age of 35. And we know that for children who have inherited, so heterozygous FH, 1 in 250 people, homozygous FH, inheriting 2 genes for familial hypercholesterolemia, 1 from each parent, it's about 1 in 300,000 people. These children can have very, very elevated LDLs. They can have LDL levels anywhere from 400 to 1,000. So that is many-fold higher than the general population. And they can develop heart disease. They can develop cardiovascular events such as heart attacks in their childhood, in their even younger than 12.5. The earliest was age 18 months. But we can see children developing early cardiovascular disease. And these are kids who have no other risk factors. So again, LDL is the driver. And how do we know this? Next slide. We can think about first the normal artery, and then we'll get into the initiation of atherosclerosis. So to understand atherosclerosis, we need to first talk about, what does a normal artery look like? What were the arteries you were born with look like? So an artery has 3 layers. The outermost layer is called the adventitia, as you can see depicted in the far right of your slide here. The adventitia contains nerve endings. It contains micro blood vessels that actually nourish the media, or the middle layer. The middle layer of artery is very well organized. It contains lots of smooth muscle cells, and the smooth muscle cells produce extracellular matrix. This provides structure to the artery. The media is really what provides the structure to the artery, and it produces, the smooth muscle cells can produce elastin and collagen that allow structure and allow for the dilatation of the artery as well. The intima, or the innermost layer of the artery, is separated from the blood by a thin layer of cells, the endothelial cells. And the intima, when it comes to atherosclerosis, is where the action is. And so the next slide. So once LDL particles leave the blood, they are less protected. So when LDL is in our bloodstream, we in our bloodstream have antioxidants. Once an LDL finds its way between endothelial cells, so the endothelial cells are that thin layer, single layer of cells that divide the artery wall from the blood. And so the LDL particles here depicted as little yellow circles, if they're in large quantities in the artery, they find their way between the little spaces between endothelial cells, and they migrate into the intima. And when they migrate into the intima, they become trapped. And then they are then they become chemically modified or oxidized. So how would it get oxidized? How would an LDL particle become oxidized? Sometimes the intima will have red blood cells, and those red blood cells will break open, and the red blood cell will have heme in it. Heme or iron can oxidize the LDL, and it's that oxidized LDL that becomes toxic. Exposure to oxidized LDL and other risk factors really poisons the endothelial cells. And one of the things that it does to the endothelial cells is it makes the endothelial cells less able to produce vasodilators, such as nitrous oxide. So nitrous oxide produced by a healthy endothelial cell really allows the artery to dilate. And why would you need your artery to dilate? Say you were running a race and you need more blood flow to your heart, more blood flow to your legs. You want that endothelial cell to be able to produce nitrous oxide, which naturally allows widening of the blood vessel and increased blood flow so that you can get more oxygen. The blood carries the oxygen. Endothelial cells, when exposed to oxidized LDL, can also become activated. And it's activated endothelial cells that produce something called adhesion molecules. And we're going to talk more about adhesion molecules in my next slide. But interestingly, eating a diet rich in cholesterol and saturated fat not only downregulates LDL receptors, as I talked about when we were talking about the liver, but it increases adhesion molecules. And adhesion molecules, as we'll find out in the next slide, where we can go, are not good. So what does an adhesion molecule do? An adhesion molecule really attracts white blood cells known as monocytes. And they bind these white blood cells to the endothelial cells. And what happens? Just like the LDL particles, those monocytes find their way into the intima. And what do monocytes do? They're trying actually to clean up atherosclerosis. And when they're trying to clean up atherosclerosis or clean up the oxidized LDL, which they view as a toxin, they view it as an unwanted player in the intima. So these monocytes are trying to do us a favor. They consume the oxidized LDL. And so when the monocytes consume the oxidized LDL, they are transformed into macrophages or foam cells. And why are they called foam cells? Under a microscope, a macrophage loaded with oxidized LDL appears foamy. And so it's called a foam cell. Immune cells also in the atherosclerotic process. T lymphocytes. Some T lymphocytes are likely to increase atherosclerosis. And for example, helper T cells increase atherosclerosis because they secrete cytokines. Cytokines are dangerous chemicals. And in one example, and I'm going to talk more about this in a little bit, these T helper cells can produce something called interferon gamma. And we'll talk more about that in a moment. Other T cells, regulatory T cells, seem to buffer the effect of the T helper cells, and they work to prevent atherosclerosis. Next slide. So as atherosclerosis progresses, smooth muscle cells that really belong in the media, the middle layer of the artery, where the middle layer, provides the structure to the artery. They sense that there's something bad going on in the intima. And those smooth muscle cells migrate up from the intima, from the media into the intima. And just like the monocytes, they gobble up oxidized LDL, again saying oxidized LDL is bad. We want to get it out of here. So they eat it up. And you can see as we're looking at this slide, this does not look like a happy cell. This looks like, or a happy artery. All these cells that become loaded with oxidized LDL really begin to look the same. The monocytes that become foam cells, and the smooth muscle cells actually become foam cells. And they undergo cell death. And what happens then? They spill their contents, which is oxidized LDL, and another monocyte or another smooth muscle cell gobbles that up. And so what you end up having is this necrotic or dead core of the plaque, and that becomes very unstable, and as you can see, quite large. Next slide. And so smooth muscle cells, which I said are normally belong in the media, middle layer of the artery, and they normally belong to be producing collagen. And they might produce collagen in the intima to stabilize that thin endothelial cell, to stabilize this thin fibrous cap, to protect the plaque from rupture. But unfortunately, T helper cells, which I talked about earlier, producing interferon gamma, they interfere with the smooth muscle cells' production of collagen. They interfere with the fibrous cap, and they make it more unstable. Not depicted in this slide, but to make matters more confusing, many plaques develop calcifications. Micro or spotty calcifications are associated with unstable plaque, which are prone to rupture, whereas plaques with larger amounts of calcium tend to be a little bit more stable. But if people have some plaques with larger amounts of calcium, rest assured they probably have other more unstable plaques that may have spotty calcification. Next slide. So what are the complications of having this unstable necrotic core to a plaque? One of the major complications is plaque rupture. And we'll talk also about plaque erosion. That's a little bit less common. But the most common complication is rupture. And rupture can occur due to a fissure in a thin fibrous cap. So a little break would be caused by inflammatory cells, such as the T lymphocytes making chemicals like interferon gamma that actively degrade or break down the fibrous cap. And so then when the cap ruptures, it rips open the plaque, exposing what we call the thrombogenic interior of the plaque to the blood. And when we say thrombogenic interior, that means that the interior of the plaque is really not meant to be seeing the bloodstream. And so the role of the blood is to try to, cause it's almost like cut to cause a scab. So it wants to cause a clot to cover up this break. But the clot can be very large, and that clot can fill up the entire lumen where the blood should be flowing. And so when the clot does that, if you think about a heart artery, if it has a clot in it on top of a big plaque, you can't get blood through there. And so any heart tissue that's downstream in that artery is going to be deprived of blood. It's going to be deprived of oxygen. And this is when we see a heart attack. Now, sometimes people can have that clot and have that clot break up rather quickly. And a person might experience unstable angina or chest pain. And that may be a warning sign that more rupture is likely to happen. And it can be a warning sign. Unstable angina can be a warning sign that a person needs to get to the hospital, needs to be evaluated. Often people with unstable angina will undergo a cardiac catheterization, a culprit lesion, a culprit plaque will be found, and a stent will be placed. And probably many people that are on this call have had stents placed in their arteries. Next slide. But what about erosion? Erosion is a relatively new phenomenon. As people are receiving more anti-atherosclerotic therapies, such as cholesterol lowering, blood pressure lowering, and blood sugar lowering medications, we have begun to see sometimes changes in plaque makeup. So instead of that very actively inflamed plaque that had the necrotic core, with lots of lipid engorged macrophages and lipid engorged smooth muscle cells, plaques can become replaced with more fibrous tissue and can become more stable, or replaced with more calcium. In these cases, we sometimes see that thin endothelial layer missing or eroded. So you still get the contents of a plaque exposed to the blood. And you may get a thrombus, a blood clot on that. And eroded plaques can cause heart attacks. The group of people we're seeing this with most commonly are postmenopausal women. So we're working on, there's lots of research going on eroded plaques. So please stay tuned for that. Next slide. So atherosclerosis doesn't just occur in the heart arteries. Atherosclerosis can occur in any artery bed. And in each case, we can see acute, meaning immediate, and more chronic complications. Take, for example, atherosclerosis in the arteries leading to the brain. Individuals can have an acute stroke with a complete blockage of an artery leading to a part of their brain. Or just like we can break up those clots that can occur, people can have transient ischemic attacks. And that is really like it's like unstable angina in some ways. It is a clot forms and then it gets broken up. For example, many of you may know somebody that's had a transient ischemic attack. What is described there is that people experience a sudden, maybe garbled speech or difficulty walking, but then it goes away rather quickly by the time they get to the hospital. And so that's a warning stroke, a transient ischemic attack. Sometimes people can get little blockages to various arteries in the brain that don't cause a stroke or a transient ischemic attack, but are enough to eat away at some of the memory areas of the brain. And people actually develop something called vascular dementia related to lots of little, either little TIAs or little areas of the brain that get disrupted due to atherosclerosis. We've already talked about the heart arteries, acute coronary syndromes, things like unstable angina or heart attacks, also known as myocardial infarctions. And we've talked about stable angina. There can be people who have atherosclerosis that know that on a particular spot in their walk, every day they're walking up a hill and they know that when they're halfway up that hill, they're going to start feeling a little squeezing in their chest, a little chest pressure. And those people are said to have stable angina. And what do we think of there? We think of supply and demand. So you may have a plaque that's rather large and it may be one of those stable plaques. But when you are pushing up a hill, you need more oxygen to downstream in your heart, and you're not able to get that much blood flow through. And so these people have stable angina. And often what I tell my patients to do is, if they know they're going to have that problem, they pop a nitro at the bottom of the hill, and the nitro glycerin helps dilate that blood vessel so that they do not get the stable angina. Your aorta in your chest can rupture. The aorta can dissect, and these are all complications of atherosclerosis. A dissection is when the layers of the artery separate. In the abdominal aorta, you can see complete occlusion, or you've probably heard of abdominal aneurysms. That's when an aorta becomes enlarged. And when we see that on an abdominal ultrasound, we regularly, every 6 months or every year, get an abdominal ultrasound to make sure we're following that aneurysm so that we know that when it reaches a certain point, we might need to operate. The kidney arteries or renal arteries can be occluded, meaning blocked, and that can happen very acutely. This is rare. But what happens if people get atherosclerosis in their kidney arteries? They can developing worsening kidney function. They're what's called BUN and creatinine go up. And we can also see people who get abdominal angina. So what is that? we have arteries that serve the blood vessels to our colons, our small bowel, and those arteries, the superior and inferior mesenteric arteries, they can get acute ischemia, and you can actually have infarctions, like a heart attack to your bowel, and you can lose a certain portion of the bowel. But more commonly, people will get what we describe as abdominal angina. So if you have atherosclerosis in these arteries, you need more blood flow to your gut after you've eaten. And so sometimes people after they've eaten, the supply of blood or oxygen to those arteries is diminished. And following a meal when you need more blood flow to digest your food, you may see people getting abdominal pain. And then the peripheral arteries, arteries primarily to the legs. You can have acute peripheral artery occlusion, where you can get gangrene to one of your legs or your foot or a toe. Or you can get, more commonly, something called intermittent claudication. Again, when you're demanding more oxygen to your legs, to your calves, to your feet, as you're walking, your demand may outstrip your supply. And so people will describe pain in their legs when they walk. And when they stop, that pain gets better. And there's certain other risk factors in addition to cholesterol that can contribute. And for what we call intermittent claudication, or not enough blood flow to the lower extremities, smoking is a very powerful risk factor. Now, these are multiple artery beds that I've talked about, but one artery bed that's not depicted here that is actually important to talk about is the penile artery, which is a branch of the internal pudendal artery. Atherosclerosis there can cause erectile dysfunction, and the medications that men take for erectile dysfunction are just vasodilatory medicines that they open up those arteries for more blood to flow. So important for me to say is interventions like bypass and stenting, whether it be to the heart or to your lower extremities or to carotid arteries, they only affect or impact 1, 2, 3 arteries at a time. But cholesterol lowering medicines, blood pressure medicines, quitting smoking, impact all your arteries at once. And so I can't emphasize enough how important it is to take those cholesterol lowering medicines that really impact all the artery beds. Next slide. So we're drawing to the end, but cholesterol can cause atherosclerosis, and it develops over time, going from the fatty streaks to lipid-rich plaques, to you can have small internal ruptures. You can have calcium getting into the artery. You can develop a vulnerable plaque, which is loaded with those macrophages, foam cells, smooth muscle cells that become foam cells, and a very thin cap separating that plaque from the blood flowing in the artery. And then we see rupture, and we have platelets, which are the blood clotting cells, and fibrin trying to protect that rupture. Or we can see complete occlusion, as you see here, where there is no blood flow through that artery. And so what's downstream will not survive. And so there will be a myocardial infarction or heart attack. Here, the last one is when those plaques reorganize, when those clots can reorganize. And you can see in the very last frame of this slide that you're left with a lumen, or an area where the blood flows, that is smaller. And so you can imagine that it's going to, people with a diminished lumen will get more angina when they try to get more out of their arteries, when they want their arteries to dilate, if there's a fixed blockage there, we'll see angina. So treating high cholesterol early can prevent the development of atherosclerosis from occurring in the first place. And that's called primary prevention. And we really stress this in younger individuals who have elevated cholesterol, whether it be from lifestyle or from a genetic predisposition. We want to get started early. But if you already have atherosclerosis, and many people on this call may already have atherosclerosis, it isn't too late. The goal in secondary prevention, or preventing a second cardiac event, is to treat all risk factors aggressively, again, to prevent another event. And you want to advocate for these proven therapies, cholesterol lowering medicines. And then for other risk factors, blood pressure lowering medicines, diabetes medicine, quitting smoking, maintaining a normal body weight. And the FH Foundation is here to help you at every step along the way. Next slide. So let's wrap up here. Atherosclerosis starts with LDL. The development of atherosclerosis requires elevated low density lipoprotein cholesterol. And one of the things you may say is, well, some people who get heart attacks don't really have elevated elevated LDL cholesterol. Well, they have an elevated LDL cholesterol. The level of LDL cholesterol that most people in the United States have is not a really healthy LDL. In societies where atherosclerosis is quite rare, LDL cholesterol may never get above 70. And so people may have very low LDL cholesterols throughout their life. But we have learned a lot from people who have genetically elevated LDL cholesterol, such as FH, who get very early atherosclerosis, even without any other risk factors, and people who have genetically low LDL who are spared from atherosclerosis, even when they do have other risk factors. There is strong evidence that inflammation is involved, but inflammation doesn't start the process. LDL becomes oxidized, and it's oxidized LDL that is a very inflammatory LDL. So it includes, inflammation includes LDL, but it includes those lipid engorged macrophages that are making cytokines, smooth muscle cells, chemicals such as cytokines coming from, like interferon gamma coming from helper T cells that actually destabilize the plaque. And there is evidence that the endothelium, that thin layer of cells that separates the intima from the blood, can become activated and produce adhesion molecules. And these encourage the entry of monocytes into the intima, where they become macrophages. Exposure of the endothelium to oxidized LDL makes the endothelial cells sick. It makes them less able to produce vasodilating chemicals that can let our arteries dilate as we need them to. And we're learning that the immune system is involved. Helper T cells destabilize the plaque by producing inflammatory cytokines, such as interferon gamma. And regulatory T cells may protect against atherosclerosis. A little calcium in the plaque appears bad. A lot may stabilize the plaque. So there's still a lot we're learning about atherosclerosis. I want to give the strong impression, because it's true, that we still have a lot to learn. But one thing we're quite sure of is that LDL starts the process. Next slide. So I'm going to turn it back over to Kat, who's going to go through a few resources, and we'll get back to questions.
Thank you so much, Dr. McGowan. That was really helpful, a great overview, and I think an insight that people don't usually get access to. And we have some really wonderful questions I'm really excited to get to. I thought we'd go through a few of the resources. I think, of course, the beginning of all cardiovascular disease prevention and other health issues, right, is how can we have a healthy a healthy diet and lifestyle with exercise. And one of the resources we have is a webinar on diet and cholesterol control, and for those who need it, medication. So we have that webinar and several others on our website. If you look at the fhfoundation.org/webinars. And then we have, you've talked a lot about the atherosclerosis and the development of heart disease and stroke and all the things that can happen. But if you want to learn more about what treatments there are to lower LDL cholesterol, you can find a lot of that information, all that information on our website at the fhfoundation.org/FH treatments. But I want to say that those treatments are generally not all, but most also applicable, right, for not just for familial hypercholesterolemia for all, but for elevated LDL, and lots of information there for anybody who's looking for that information. We thanked our sponsors at the beginning, but we also would like to thank all of you who make donations to the FH Foundation. It really helps us to put these programs together. And we thank you also for your questions and your input along the way, because that helps us to understand what do people want to learn more about. So if you would like to make a donation to the FH Foundation, we would be so grateful. And you can find that also on our website. So we'll move to questions, and I'm going to turn off the slides, and we will jump in with questions. And I think it is appropriate to start with, what about lifestyle actions to reduce cholesterol, nutrition, and exercise? Dr. McGowan.
Yeah, thanks so much for that question. Absolutely. We, at the FH Foundation and in my practice at Dartmouth, I strongly recommend lifestyle modifications. And so when people come with either a genetic cholesterol abnormality to see me, or come having had a heart attack, one of the first steps is dietary modification, reducing saturated fat, which downregulates LDL receptors, reducing things like eggs, cheese, full fat dairy products, red meat. And so we go through, I have a practice of taking a dietary history. This is actually a practice I learned from Mary Card, who's one of our FH employees, but we worked together in a lipid clinic for many, many years. I take a dietary history from a patient, and I write down everything they tell me they typically eat for breakfast, lunch, and supper, and snacks. And then I offer suggestions for everything I think needs correction. And I preface it by saying, I'm going to tell you everything. And you can figure out what's a deal breaker and what's not a deal breaker. And we can usually come to an agreement on things that, big ticket items that they're willing to make changes on. And we can usually see substantial improvement in the lipids. What do you expect from diet? 10, maybe 15% reduction. So it's important for people who have genetic cholesterol abnormalities or who have had a cardiovascular event to recognize, in general, it is not possible. I would go so far as say it is not possible to fully normalize a lipid profile when a person has a genetic dyslipidemia or has had atherosclerosis with diet alone. We want, in primary prevention, remember, before somebody's had a cardiovascular event, the ideal LDL is an LDL less than 100 milligrams per deciliter. Someone who's already had a cardiac event, we want them less than 70. So to get less than 70, get there is hard. And so be open to medications, but also be open to the beneficial effects of lifestyle.
Thank you so much. And I think you talked about, maybe you could say briefly, you talked about what the say goals for LDL cholesterol might be for primary and secondary prevention just now, but maybe just to quickly reorient people to what is atherosclerosis? Like, what are the conditions that put you in that category? How would you be diagnosed with atherosclerosis? And then maybe also the question is, how would you be diagnosed with FH?
Mhm.
And maybe you could touch on also like severe hypercholesterolemia in addition to FH.
Okay, so what things constitute atherosclerosis? Well, when we saw that slide, those are some of the things. So things like having had a heart attack, things like having had angina, if you've had a stent in a heart artery, or a bypass surgery to your heart, if you've had a carotid endarterectomy, which means they've opened up your carotid artery because you've either had a stroke or a TIA, or it's been found and that your doctor has recommended that. If you have intermittent claudication, pain in your legs when you're walking, your doctor may check something called an ankle brachial index, so a blood pressure in your ankle and a blood pressure in your arm. And if the ankle brachial index is less than 0.9, you have peripheral vascular disease. So those are some of the ways to diagnose atherosclerosis. One of the things that we're doing more commonly these days is something called a coronary CT scan for people who are sometimes hesitant to go on a medication, but they say, if I have plaque, then I'm more likely to go on a medication. We will do a coronary CT. This is a study. It's a coronary CAT scan that is looking for calcium in your coronary arteries. The only place calcium goes is inside plaque. So the amount of calcium you have in your plaque can be a measure of plaque burden. So the only normal amount of calcium in an artery is 0. So people who have calcium in their heart arteries have atherosclerosis, have plaque, and that's we can diagnose atherosclerosis in that case by a non-invasive test that gives you the amount of radiation of a mammogram, 1 millisievert. Sometimes people going on a treadmill test, running on a treadmill, or having a nuclear stress test can be abnormal. And so various parts of the heart may not function properly during the stress test. And that too would give you the diagnosis of atherosclerosis. Your next question was how to diagnose FH?
Well, let me think, because there was a question about the tests that one might use to understand heart attack or atherosclerosis risk or cardiac event risk. And I think you just touched on almost all of them. Is there any other test that people might want to be aware of?
No, I think those would be it. The stress tests and we get stress tests only if somebody is symptomatic. If somebody is describing, pain when they walk, or so that would drive a stress test. What would drive a coronary CT is something different. It's people being inquisitive to know, do I have plaque? And so I would say it's more a coronary CT is going to be much more telling in people in middle age than it is in people who are younger than that.
And is that the same as the CAC score that people would?
Yes, it's exactly the same CAC. It's the CAC
A lot of
score.
people might know it as a CAC score.
And they might know it as an Agatston score as well.
So the second part of that question, and you're in the process answering some of the questions that are coming up. Thank you. The second part of that question was sort of, I guess, where, what's the level at which you really worry a lot about LDL cholesterol, and it might be severe hypercholesterolemia, or it might in fact be FH. How do you diagnose those conditions?
Right. So familial hypercholesterolemia can be diagnosed either phenotypically, which means on the basis of physical findings, family history, and lipid levels, and I'll get to that, or genetically. There are certain genetic mutations that are commonly associated with familial hypercholesterolemia. LDL receptor mutations, ApoB mutations, PCSK9 gain of function mutations, and a very rare LDL receptor adapter protein mutation that's a recessive disorder. The other three are monogenic, meaning you just have a single gene, can cause FH. So in the United States, most people are diagnosed phenotypically, and it starts with looking at an LDL level. In a child, if a child has an LDL level greater than 160, you should start thinking FH. If an adult has an LDL level greater than 190, you should start thinking of FH. And then take a family history. If there's a strong family history of hypercholesterolemia or atherosclerosis, early cardiovascular events, start thinking of FH. And then there are physical findings that we see with familial hypercholesterolemia. So we don't see them in children, but we do see them in adults. And we don't always see them, especially if somebody's been on a cholesterol-lowering medicine. They may not have these findings, but we can see little cholesterol deposits under the eye, above the eye. In the iris of the eye, the colored part of the eye, we can see a little circle of white, and that's called corneal arcus. That is a cholesterol deposit. And we can see thickening of the Achilles tendon, and that Achilles tendon can be replaced with cholesterol, and that's why it gets thickened, and it can be prone to rupture. So thickened Achilles tendons, xanthelasmas, or cholesterol deposits around the eyes, those all are cues that this person may have familial hypercholesterolemia. And then there are many people who have what we call polygenic dyslipidemia. They've inherited a whole bunch of different genes from their parents that all lead to slight elevations in cholesterol, and when added up collectively, may lead to an LDL that looks like FH. And those people with polygenic dyslipidemia are also at increased risk for premature cardiovascular disease.
Thank you. And I think we're close to time, and we have so many great questions, a lot of them about diet. And I would refer people to the webinar that we did on diet for those, because I don't think we have time to get to all of them. But I think a fundamental question is, can you get is lowering your LDL, is that the goal? And can you see reversal of plaque or of deposits? And then I think related to that question, I'm not sure I fully understand. I think you might have said something about postmenopausal women that might have been misheard. Do you is there anything that would deter postmenopausal women from taking statins, or to the contrary? So is lowering LDL with medication the
Absolutely not.
Right. Okay. And what can we hope for?
So the first part, can you reverse atherosclerosis? We used to say no, but we can. And first of all, excuse me, managed to get through almost the whole thing. So there have been early studies with children that have shown that they get thickening of their carotid, and statin treatment early in life can reverse that. So that's really important, and a message for early treatment. Then now that we have so many things in our armamentarium, we can see some reversal of atherosclerosis, even in people who already have it. There was a trial called the Glagoff trial, which patients were on statins. They could be on ezetimibe, and they had a PCSK9 inhibitor. In this case, it was evolocumab added. And and then there were intravascular ultrasounds, which actually looked at the plaque, and done at baseline, and then after about 18 months of therapy, if I remember correctly. And you could actually see some reversal of plaque for people who got very low LDL, people who got LDLs down around 40, 50. So that is really exciting, because we have so many therapies now. We have new therapies all the time. And then finally, the postmenopausal woman story. I hope I didn't misspeak. Women are relatively spared from symptomatic cardiovascular disease until menopause. After menopause, and women have smaller arteries than men, women accelerate the pace of atherosclerosis. So certainly, if a premenopausal woman wants to be on a statin therapy because she has very elevated cholesterol, we would certainly recommend that. The only time we don't recommend statins is in women who are pregnant or breastfeeding. So a woman with FH could be treated right up until she decides to get pregnant. Postmenopausal women with elevated cholesterol, there's no reason not to treat them aggressively.
Okay. Thank you so much. So I think, I mean, what I take away is that there's a lot we can do. We got to start early. Atherosclerosis develops over time. LDL is key. If you want to ask which came first, the chicken or the egg, the LDL or the inflammation, what I heard today is the LDL came first. And so getting our LDLs down is so important, especially for people who start high. And of course, we can never be misunderstood that, of course, diet and exercise are key fundamental parts of the formula for a healthy life. But if we want to prevent heart disease and stroke and all the other forms of atherosclerosis, I hope people from this webinar have understood sort of what some of the keys to that are. Again, we have great resources on our website, including some questions were about what kind of doctor to see. And we have a search function on our website where you can find a specialist in preventive cardiology or in lipidology who understands cholesterol and heart disease and would be able to help you. So please feel free to visit there. So Dr. McGowan, thank you so much for a great webinar.
My pleasure. And one last thing I would like to say is that I do tell patients that I see in my clinic that a really healthy lifestyle might allow you to be on just a little bit less medication. But we don't want to give the impression that medication is not needed.
Right. And I think fair to say most of the people who joined here have some form of elevated cholesterol. Otherwise, we wouldn't be here. So that is, we're so glad that you all made it and joined us. And thank you for all your questions. We will use those to inform future webinars, and we will do our best to get back to you directly if we haven't been able to answer your question today. Thank you so much.
Thanks.